Hi, my name is Suzanne Dickinson, and I'm an instructor here for the ultrasound program at EVMS. And today we're going to be talking about scanning the pelvis or bladder as it relates to a fast exam. So for today's session, the objectives we're going to be covering will be an introduction to the clinical applications of our POCUS exam, machine setup and options. So I will show you some of the things you need to be aware of on the machine itself, patient setup and the acoustic window you'll be using to look in the pelvis, and how to acquire the images, and some pitfalls and pearls that you'll run up against, and an SPI snapshot. And don't forget that you can find your scanning cards on the Blackboard website. So for our clinical application, the purpose of doing these pelvic exams, or the bladder as it's often called, referred to, is so that you can look for fluid that's in the pelvis, in the potential spaces of the pelvis. So this might be a patient that shows up after some blunt trauma, and so you'll be doing a fast exam, and this is one of the components of that fast exam. For this, you have to consider where those potential spaces are and where fluid collects in the pelvis. So in the female, you have the rectouterine pouch. It's also known as the pouch of Douglas or posterior cul-de-sac. So in GYN circles, you'll hear it referred to posterior cul-de-sac most often. There's also the vesicouterine pouch, also known as the anterior cul-de-sac. And that'll be that area that is between the bladder and the uterus. And it's smaller than the pouch of Douglas. For the man, we have the vesicorectal space, which is equivalent to the pouch of Douglas or posterior cul-de-sac in the female. So for our machine setup, remember to enter your information as instructed on Blackboard. If we move to the machine, you'll be pressing your patient button. And when you press the patient button, it'll bring up your patient ID, and just follow your instructions on the Blackboard as to what you want to put in that field. When you press patient again, it'll take you out of that screen. Also, you'll want to select a preset. For that, you want to press the exam button. When you press the exam button, it'll give you a menu. You will select adult abdomen, pressing the set button to do so. The probe you'll be using will be the curvilinear. And as you recall, that's our larger curved probe that allows us to see larger areas. Now, bear in mind that you can use, I'm going to put this probe back and I'm going to bring out this other one just as a caveat. If the phased is the only one that you have available, you may use this for this exam as well. But the curvilinear is the optimal for this one. Also remember, if we look at our machine, that the preset is going to already set a certain depth for you. Here are your depth buttons. So you don't need to touch those initially. It's going to already set a default for your gain, so you don't need to set that initially. And also for your focal zone. So keep those just the way they are until you begin to scan. In addition, the TGC should be set central, and I'm going to just slide these in the center of their slide. And this is all set up for before you begin scanning. You can start to adjust these once you start scanning. So let's look at patient position. Your patient is going to be in a supine. If for any reason it's a trauma patient that is off to one side or the other, you'll work with that. But if you can have your patient lie down in the optimal position, it'll be in supine position. Your probe marker by convention for any abdomen scan is the probe marker, which you can see here, must in long axis face up towards the patient's head. In short axis or transverse axis, we turn the probe or pivot 90 degrees counterclockwise so that the probe marker is pointing to the patient's right. Okay? The probe movements, if you recall, are going to be our heel toe, our sweep or fan, our pivot or rotate, and by pivot and or rotate, you can also anchor the toe and move the heel, or anchor the heel and move the toe in order to align. So for our acoustic windows, the one available is going to be midline. So if we look at our patient again, and at the level of the umbilicus, which is about where the L4, L5 is, down to the pubic bone, we are looking at the false pelvis all the way down to the pubic bone. But we want to look in the true pelvis. So when we place our probe, we might be placing it initially right in between the two structures, the umbilicus and the pubic symphysis, and then sliding our probe down, and then we want to look past the brim into the true pelvis where our bladder and our reproductive organs live. To do that, you may have to toe the probe a little bit. In transverse, you'll want to just aim it into, or you might angle it into the pelvic inlet to be able to see your structures in transverse. Today's image is going to be in long axis, however. For image acquisition, as we talked about, you'll be adjusting your depth and your focal zone gains, TGCs, and probe orientation once you begin scanning. And you'll want to think about the location of the bladder. Like I said, the bladder and the reproductive organs are in the true pelvis. The bladder lies anterior to the reproductive organs. And the relationship of those potential spaces is important too. Remember where they are relative to the bladder and the reproductive organs. And you're going to be sweeping through the pelvis from sidewall to sidewall, looking for fluid that could be anywhere in the pelvis, as that posterior cul-de-sac moves outward towards the paracolic gutters. So your depth, remember that we must include the reproductive organs. We're not just looking at the bladder, because those potential spaces exist deeper all the way to the rectum. All right, so let's do a little bit of scanning. Add some gel to patient, to your probe. Now, I'm going to toe my probe so that I'm looking down into the pelvic inlet. We have too much depth on this image. As you can see, we have a lot of extra space down here. If I center this right in the middle, here are the reproductive organs. So we've got too much through transmission from the bladder, so we have a number of problems to deal with here. But let's deal with our depth first. We just want to include the cervix on a female. So I'm going to adjust my depth. It's just a little less. Oop, too much. Because any fluid is going to be behind, or most of the largest pocket of fluid is going to be behind the cervix. Now we need to address our gains. So our gains are very bright here. This is in part due to the preset starting us too bright to begin with, but it's largely in part because the through transmission or posterior enhancement coming through this very full bladder. So I'm going to start with my overall gains first, and then I might touch the posterior TGCs just a touch to bring to get rid of all of those extra echoes. My focal zone, I'm going to put my focal zone at that posterior aspect of the cervix, because remember, that is going to be where the posterior cul-de-sac lives. So right here is where the posterior cul-de-sac is going to live. Up here is where the anterior cul-de-sac is going to live. And so these are the places that you want seen on your image. I'll lighten my touch just a little more. So I want you to be able to be sure that you sweep all the way through the true pelvis from either side, because fluid can also move outwards towards the lateral sidewall. You can even practice turning transverse and scanning through. Now, be aware that in the female, you may find trace amounts of fluid when you're scanning through. And I'll put my arrow right here, which is normal to find in a female related to her cycle. But this is the value of sweeping through, because this was not deep in the posterior cul-de-sac, but I was able to scan through and find it right here. But it's only a small amount. The image you want to acquire is at midline, with the female, the cervix in view, with the male, the prostate in view, and your focal zone set at the posterior aspect of the cervix in the female and the prostate in the male. Freeze your image. Okay. Let's talk about some common artifacts you may see. Before I do that, I want to point out that while I was showing you a female pelvis in the live imaging, this is an image of a male pelvis. And you can see the prostate and the seminal vesicle. And in this one, you can actually see a tiny stone. Deep to that stone is where you'll find free fluid in a male. So some of the common artifacts that you'll see will be anterior cystic noise, which occurs in that anterior aspect of any kind of fluid-filled structure, in this case the bladder. You'll also see reverberation. And reverberation in this particular image is just some linear densities that are repeated from anterior to posterior by that bracket. Posterior acoustic enhancement, which is commonly seen deep to a cystic structure, is right here. And reflective shadowing, or even dirty shadowing, it will often be seen in gas-filled bowel, here and here. Now, as for your labeling, you'll underneath the patient's last name, you'll be putting bladder. And in the black portion of your image, be sure to put your name and ID, and bladder or pelvis, either one is fine. And for your anatomy, just refer to your blackboard for what you're expected to label. And you can do this in your software so as not to eat into any of your scanning time. Some pearls and pitfalls that you may encounter. Don't start scanning until you've selected your preset, entered your patient information, and centered the TGCs. Do set your depth to include the reproductive organs. Don't forget to set your focal zone at the posterior aspect of the rectouterine or vesicouterine pouch, which means you'll be setting your focal zone at the prostate on the male, the posterior aspect, and the cervix on the female. Do set your gains for an anechoic bladder, but don't set so dark as to compromise the gains on the reproductive organs. And don't forget to sweep or fan through the pelvis and explore. And now for an SPI snapshot. What does that time compensation compensate for? It compensates for attenuation. So the deeper the sound beam travels, the weaker it becomes. The amplitudes of the returning echoes from similarly deep structures are lower. And those amplitudes of the returning echoes determine how bright the gray tone should be. So with all things equal, if nothing else was adjusted, and we put the probe on a patient's liver, the anterior liver would appear brighter than the posterior liver because those returning echoes from the posterior liver have a lower amplitude. So the liver imaging should be adjusted for uniform mid-gray echoes from the anterior to posterior, and we can accomplish that with the TGCs. Let's take a look at an image. This is an image of the liver and at the renal interface. But you'll notice that the posterior portion of the liver is hypoechoic to the anterior portion of the liver, when it really should be uniform from the anterior surface all the way to the diaphragm, the posterior surface. Let's turn to a patient and see how we could adjust for that. Deep breath in. If we go to the same position, our depth is okay, our focal zone is okay, but look how hypoechoic the posterior liver is. And we can adjust for that. So we're going to take our posterior TGCs, slide them out, and now the liver is uniform from its posterior aspect, from its anterior aspect, all the way down to its posterior aspect. And that's how you would adjust TGCs. That's it for this time. We'll see you on the next episode of Ultrasound Soundbites at EVMS.